Hello, I'm Carl. I'm a perfusionist at Wythenshawe Hospital. Wythenshawe Hospital is a UK ECMO centre, VA and VV, and it's also a UK transplant centre for hearts and lungs. My talk is going to talk about the Wythenshawe experience with this. Firstly, I'm going to go into some of the BIVAD hardware options that are available, then go into which choices Wythenshawe tend to use there, with a focus on the CentriMag, which is the most common one that we use. And then I'm going to go into a little bit of detail about the steps to inserting a BIVAD at Wythenshawe Hospital, some of the tips and tricks that we use for that, and then go into some ICU considerations, common issues and emergencies that might occur as part of the circuit setup. So on the table on the left just shows some of the BIVAD hardware options that are available across the world. Clinical considerations that clinicians will take into account would be the fact that it would be a long-term versus a short-term. What we define as long-term would probably be anything over 2 months. Short-term would be a week or less, and in between would be the medium-term. Another consideration is the continuous versus the pulsatile flow. Pulsatile flow provides more optimal distal organ perfusions, and continuous flow less so, but it comes at the expense of hemolysis generation in the circuits. This used to be much bigger of a problem than it is now, as the design elements, the bioengineering elements of the circuits now have a much more keen eye on that kind of problems. The last thing that I wanted to talk about here would just be the multidisciplinary team input requirements, not just from the anaesthetists and the surgeons, but also in the ICU afterwards for these kinds of patients. As the speaker before mentioned, it's a bridge to transplant or a bridge to recovery, and that process is a 30-day plus process in some cases, meaning that it needs to have perfusionists on board, it needs to have nurses on board, and also it needs to have other professions that you might not expect, physiotherapists, and then radiographers as well. So the Wythenshawe choices that we use here would be the HeartMate 3 for long-term LVADs, BIVADs, the CentriMag, the most common, and then recently the IMPELLA 5 as well, as the IMPELLA 5 is considerably less invasive than the other two ones. This is the CentriMag system here. Down at the bottom is the magnetically suspended pump. It can support a patient from weeks to months. It's no friction pump, meaning that there's less hemolysis. Magnetically levitated means that there's no bearings, and that means that there's less stasis and less clot risks on the edge of the pump. At the back here is the console itself. It's usable without the screen that's attached to it, which is really helpful for CT scan runs and other types of movements for the patients that could do without as much equipment as possible. Just a quick one on the theatre prep. Again, with the long-term sort of aspects of what we're thinking about the patient, the right femoral sheath is added just for potential renal filtration afterwards. We take a TEG and a baseline ACT for coagulopathic state, as that tends to have a problem later on as well. And then we obviously make sure that we have a TOE as well for placements. This slide is just talking about the actual intraoperative procedure that we go through to put in a patient on a BIVAD. We will put the patient initially on VA ECMO. We'll then put the rest of the cannula in for the BIVAD, and then we will come off of VA ECMO and then initiate BIVAD. So we do that in a very specific order. Firstly, we'd add a 32 single stage cannula to the right atrium and a 20 EOPA via a Dacron graft, and we'd initiate VA ECMO on the patient. This means that the surgeons can quite easily manipulate the heart in order to place the other two cannulas, which would be a 32 malleable on the LV apex, and then a PA 21 HLS return via a Dacron graft onto the PA. Once the additional two cannulas are attached, all of them will be flushed with 100 mils of heparinized saline to prevent any stasis in the tubing. This is done immediately after the cannula is applied, basically. Step 3 is that we'll have a stop moment, and we'll make sure that we'll discuss the following in terms of how to go from VA ECMO to the BIVAD. As you can imagine, any errors with this process can cause huge catastrophic issues with the patient. So the RA drainage from the ECMO will be moved to the LV apex, and that will form an LVAD. The LVAD will be initiated, and then a second set of CentriMag lines will be handed up to the table, and that will go from the RA to the PA, and that will form the RVAD. The reason that the LVAD is initiated first before the RVAD is to prevent pulmonary edema, as that's quite a common issue with initiating them. So after that, how exactly that will be dealt with has been discussed at the table. They would disconnect from ECMO and initiate the LVAD swap, which would take less than a minute or two. After the LVAD and the RVAD have then been initiated, they would be using a TOE to check the septum location. If the TOE leans either left or right, then they will adjust the blood flows on the LVADs and the RVADs in order to facilitate optimal cardiac output. This is just the same information again with the table, just to show the locations of the cannulation sites, which cannulas will use typically for that, and then what temporarily those sites will be used for the ECMO, and then their eventual destination. So it would be drainage from the LV apex for the LVAD, through to the CentriMag pump, in through to the ascending aorta via the Dacron graft, and then stop moment, added up the second CentriMag, draining for the RVAD, draining from the right atrium, through the CentriMag, and then back up to the Dacron graft again. So there's some little tips and tricks in terms of what we'd like to use to tunnel the cannula, to make things better for the patients afterwards. We tunnel the cannula through the skin with a sterile glove and finger. So they would take a sterile glove, put it on the edge of the cannula, and then tunnel that through the center of the chest. I've got a picture of what that looks like on the outside afterwards. But we feel that it's more secure for CT scan runs and other types of runs. We've got a bung here, which they use instead of... they use to keep the purse strings in place of the cannula as well. And then lastly, we've got a holster here that will attach and keep the tubing in place. We don't want to have any tension on the tubing. More tension on the tubing across a 30-day period causes damage, breaks, weaknesses in the tubing, which we want to completely eradicate. The last thing that I've written down here as well is we've got a 24-hour oxygenator that's kept in the LVAD. As we go on to VA ECMO, we have some great interchangeability with the CentriMag system, and the fact that we can chop in and chop out oxygenators and pumps as we need to. So they will leave the oxygenator in an LVAD for 24 hours post-operatively. This is because they want it to effectively be a quote-unquote clot catcher. Anything that comes from the LV apex that would otherwise go to the ascending aorta will then get caught in the oxygenator. And after 24 hours, the oxygenator, when that risk is deemed to be a little bit less, will be chopped out. On the right-hand side here, we've got what it looks like on the outside. The holster's keeping things in place. Everything is sutured to the skin in order to facilitate these kinds of regular scan runs that the patients go on. Some of the surgeons as well will take the drains and connect them to cell saver, but this is depending on where the patient was during the procedure itself. Circuit changeout would be done every 30 days unless they were imminently due for a transplant. And again, MBT input from perfusionists, physiotherapists, and radiographers is helpful at this stage as well to make sure that nothing comes out. Common issues that they run into on the ICU would be a blood flow drop. Why is that? Because the non-occlusive centrifugal pumps are preload and afterload dependent. And the important thing, as with all the things in medicine, is to find the sources of it. So is the source from bleeding? Is it from sepsis? Is there kinks or changes in the cannula positions that will cause any issues? Last slide as well is emergencies. How do we deal with emergencies? What kind of emergencies do we have? So there's motor failures, in which case emergency backup ones will be there available just to spot to. This one that we've got is from a wiring that's been broken in the cannula. The cannulas are wire woven and wire bound, and as patients are undergoing physiotherapy, those areas can take some strain, and then this is spiked out. If a patient was to sit up, then there's a potential that that would pierce the actual tubing itself. So a piercing like that would cause either an air entrainment if it was on the negative pressure pre-pump head, and then it would cause a bleeding if it was on the positive pressure. Thank you very much. The conclusions are that the short-century BIVAD approach is a valid and pragmatic approach to BIVAD, especially at a VAD/ECMO center where we would need both the equipment to work for both of those approaches. And then MDT collaboration facilitates the long-term care of these difficult patients, and simple tips can be put in place to minimize the occurrence and severity of patient harm. Here are the references. If you're interested in the technique, then they have a more detailed version of it there. And thank you. Any questions?
Thank you very much, Carl. Sorry for, is there anybody who has any question for Carl? We are running late of time, so we will follow to the next session. Thank you for your participation in our webinar.
Thank you.